All right, everyone. We can get settled down and get to the second half of our morning. It is my pleasure to introduce Dr. Jacob Walker, Assistant Professor of Medicine and Division of Geriatrics at University of Colorado. Dr. Walker has a unique background in training in both geriatric team-based care and HIV specialty care, and currently practices in both disciplines across multiple clinical settings. His research interests focus on integrating geriatric principles and tools into more traditional HIV care settings through an implementation science lens. Particular areas of research interest within HIV and aging include polypharmacy, dementia, HIV-associated neurocognitive disorder, and frailty. And without further ado, thank you, Dr. Walker.
Thank you, Dr. Hazra. So as he mentioned, I am first and foremost a geriatrician. It's very nice to be welcome into HIV-related spaces. And it's very nice to be welcome back to the University of Chicago, where I did my geriatrics fellowship. Didn't miss the weather, but it's wonderful. I have no relevant financial relationships. So when asked to give a talk on optimizing care for older adults, that's a lot to cram into a half hour. So I'm going to give some big overview of key themes in HIV and aging that researchers are currently working to address. And I want us to all be familiar utilizing some evidence-based geriatric screening tools within the HIV clinic, and especially focusing in on medications. Now we can optimize pharmacotherapy for older adults with HIV. I was asked to frame this around updates from CROI 2025, which I was not able to attend, so I opened up the abstract book. And I was wondering, can I even find any geriatrics papers? Like, are there any aging updates from CROI? And I'm thinking, oh, great, there's some perspective pieces, a little frailty. Oh, God, it just keeps going and going and going. There are dozens and dozens of trials presented at CROI looking at the health of older adults with HIV, because we are all seeing patients with HIV getting older and wondering, how do we best help them? So there's a lot. I'm not going through all of these. They all kind of fall into just a few buckets, a few kind of key themes and questions. So summarizing the goals of all these studies for you, people are asking, do newer antiretroviral therapies work the same or as well in older adults? How can we optimize their non-antiretroviral medications as people age, with a lot of focus on statins and GLP-1 agonists that I'll talk about? How do we identify the older patients at the greatest risk for those mobility-related outcomes like frailty, falls, and fractures? How do we prevent and detect neurocognitive decline in long-term survivors? And then sort of a subcategory I'm not going to talk about, but is really relevant to our first talk today, which is how do we overcome CNS reservoirs of HIV in the quest for a cure? And then real broadly, how do we improve overall quality of life for people with HIV as they age? These questions very nicely fit into the 4Ms of geriatrics, which I'm sure many of you have heard of before. This is a health systems framework designed to help all of us prepare the healthcare system for an aging population in general, but it works really well as an HIV-specific clinical framework and is obviously useful to researchers, most of whose questions fall into one of these buckets. It's also a great starting point for describing what a geriatrician is, so that when people come to see me, they don't think they've been referred to hospice, or a Medicare specialist or a nutritionist. I've kind of heard it all. You can tell them this is what a geriatrician loves to talk about. I'm just going to go through the 4Ms and try to answer these research questions with some of the data from CROI. So starting with medications, the big question is, do our newer antiretroviral therapies work as well in older adults? And it's important to remember this is not a given. Like, we don't know that medicines are going to work as well in people in their 70s, 80s, and beyond because of changes in pharmacokinetics. So we have slightly decreased absorption, very different drug distribution, different metabolism, especially renal clearance and excretion. Also worth keeping in mind that as we age, our total body fat increases up into our 60s, then starts to decrease. Total body water decreases with age, as well as lean mass. That really changes the persistence of a drug in the system and how it's cleared, increasing the risk of side effects for most medications. So it's not, again, not a guarantee that any new therapy for HIV on the block is going to work as well in our older adults. One study I want to highlight from CROI testing this with bictegravir-based regimens is the BF-TAF elderly switch study. This was in 520 virally suppressed Kenyan adults over 60 who were randomized to a bictegravir-based regimen versus their current first-line regimen that they were already on, the vast majority of which included TDF. Very, very fun to see in focusing trials on older adults is that a subset received bone mineral density screening. 60% at onset had osteoporosis, which is a bit high compared to what we see in the US, but important when we're talking about tenofovir-based regimens. At week 96, they saw no difference in viral suppression, so still greater than 97% were suppressed. No difference in bone mineral density, which is not too surprising at a 96 weeks because our bones change so slowly over time. No difference in adverse events. There were actually more discontinuations in the control group, usually due to renal dysfunction, and no difference in weight gain. Though there were more individuals that had a higher or greater than 5% weight gain. When I am talking to my older adults about switching to an integrase inhibitor-based regimen if they're not already on one, it's usually not one of my huge concerns. I'm often much more worried about weight loss as people age into their 70s and beyond. And so their conclusion, which I think is sort of broadly applicable based on what we've seen with integrase inhibitors so far, is that a first-line switch strategy to a bictegravir-based regimen was effective and safe in older African adults and associated with less requirement for treatment modification. So especially if you have someone on TDF, good to know we have safe, effective options as they age. The other broad category of antiretrovirals people are asking about is how do these long-acting therapies work in our older adults? One group looked at is an Italian cohort study, the GEPO cohort. They took all of their patients who had been started on long-acting cabotegravir rilpivirine with a mean age of 67, about 20 years of ART experience, and a relatively low burden of drug resistance, which is a huge consideration for older adults when switching to long-acting regimens. Many of these folks have had many therapy switches over the years. They were quite multimorbid, 2/3 having multimorbidity, and about 1/3 having polypharmacy, which is actually lower than we tend to see in the US. And at median follow-up of 17 months, 92% were still receiving long-acting cabotegravir, pretty good. There were no virologic failures. And the 6 discontinuations they did see were all sort of things that you might expect to see with most new drugs. So a couple odd side effects, 1 patient death, patient choice, clinician choice, and an HBV flare. So nothing, no alarming signals in cabotegravir in the GEPO cohort. A few months later, this was not at CROI, but I think at ID Week, they saw similar results in the relativity cohort out of Spain. So this is a similar age group, similar number of patients switching to cabotegravir. The difference being that the folks in Spain had a much higher burden of resistant mutations, about I think it was 6% of patients, with no discontinuations of cabotegravir at about a year of follow-up. So conclusions are that the long-acting cabotegravir combination is safe and effective in older people living with HIV, despite a long history of ART and our higher prevalence of multimorbidity and polypharmacy, and that older age should not be a barrier to long-acting regimens. In fact, in practice, it may actually be a benefit as people struggle more and more with medication adherence. So that gets into, if we have great options for antiretrovirals, how do we optimize our non-antiretroviral medications for older adults? Again, I'm going to focus on just a couple of drug categories here, starting with statins. So a big topic of CROI this year was updates from the REPRIEVE trial. We know from REPRIEVE that the time to benefit in low to moderate risk adults with HIV for preventing major adverse cardiac events is about 3 years. It's true in high-risk patients in the general population. And we know from years of use that statins are effective for primary prevention in older adults and very well tolerated, despite what you might read online. Some of the updates of REPRIEVE from CROI are that pitavastatin appeared most effective in the patients with pre-existing plaques. So we know that some patients may benefit more than others if they have already ongoing arterial calcification. We saw that frailty, though it increased the risk of major adverse cardiac events amongst those patients in the REPRIEVE trial, did not modify pitavastatin's effect. So patients who were frail and receiving a statin still benefited for cardiovascular primary prevention. There was no apparent harm from pitavastatin on cognition, sort of verifying some theorized harms from statins. And there was even a study looking at statins as potentially protective against incident frailty. So there were some methodologic questionable choices in this trial. So I don't want to say that statins, like confirmatory statins prevent frailty, but it's a route of active investigation. And that leaves me with sort of mostly a professional opinion, which is that we're likely underutilizing statins in older adults with HIV. We're probably underutilizing them in older adults in the general population, but folks with HIV may be even more likely to benefit. However, they are likely overprescribed during those final years of life with a time to benefit of 3 years. Prescribing someone whose life expectancy is less than that, they may not see any real long-term effects. Now, statins are notorious for drug-drug interactions with some of our antiretrovirals. So I want to point out an area of huge concern in my own practice is polypharmacy. Depending on the cohort, depending on the part of the country you're looking at, the clinic you're looking at, anywhere between 30 to 70% of patients living with HIV are prescribed medications with at least a moderate level of interaction. Even if you take antiretrovirals out of the equation, anywhere between 50 to 75% of patients still have what we would consider polypharmacy of 5 or more prescription medications. Many are on potentially inappropriate medications for older adults, and many are on multiple anticholinergic medications, which are higher risk for side effects in older adults. So doing a thorough med review every time you're thinking about prescribing a statin, every time you're thinking about switching ART is critical as your patients end up on more and more and more medications. One of those medications that has become increasingly popular is our GLP-1 agonists. This is probably the med class I get asked about the most in practice. And I want to highlight there are a lot of great things that we hear about. GLP-1 agonists work well in older adults for weight loss. They work well for diabetes. They have the added benefit of limited hypoglycemia risk. There are cardiovascular benefits, renal benefits, more and more findings of benefit for steatohepatitis, and may, according to one abstract, even help with reduction in alcohol use. So there's a lot of great reasons to prescribe GLP-1 agonists in older adults, and they appear effective for these goals. The cons and reason you might want to avoid them in someone in their 70s or older, primarily weight loss. There's a U-shaped curve with weight. As we approach the extremes of age, people who are underweight are more likely to suffer from functional decline and death. There are a lot of GI side effects. Anecdotally, we see a lot more of these in geriatrics practices with GLP-1s, mostly due to slowed gastric emptying. There's also the concern for a lack of durable effect. Patients don't necessarily continue to maintain that cardiovascular benefit or weight loss once they stop the drug. And then, of course, cost and access is a huge concern from an equity standpoint. The big caveat in all of this, since many of these pros and cons apply to our younger patients as well, is that while they have proven efficacy for diabetes, weight loss, and cardiovascular disease, adults over 75 are not well represented in trials of GLP-1s. For most of these trials, the mean age is in the low 60s. So it's not that older adults were excluded entirely, but at the extremes of age, we just don't have a lot of good data about their potential risks. There's a higher concern in our older adults that with GLP-1 induced weight loss, we're going to see loss of muscle mass. Remember, lean mass decreases with age. Anytime we lose weight, we lose muscle and fat in conjunction. And if someone is already prone to low muscle mass, getting rid of any of that puts them at a higher risk of falls and fractures. Again, there's also a potential for a U-shaped morbidity curve with weight loss. We don't really know how much weight loss is too much weight loss in our older adults. All right, we have a Slido question on medications. Put yourself back in the clinic and you are considering starting a statin for primary prevention of cardiovascular disease in a 72-year-old with HIV. What is true regarding potential benefits of statin therapy for primary prevention?
Don't bring around a cloud to rain on my parade. Don't tell me not to fly. I've simply got to. If someone takes a spill, it's me and not you. Who told you you're allowed to rain on my parade? How much am I banned out? I'll read my...
I didn't pick the musical cues, they just happened to us. All right, so most of you are pretty clear on this. Statins are less likely to be beneficial in patients with limited life expectancy. Again, if someone's life expectancy is at about the 3-year mark or less, they are less likely to see those cardiovascular benefits. And I just want to call out for the wrong answers. The reason that B is incorrect is that don't forget that patients at the highest risk for cardiovascular disease are more likely to benefit from statin therapy, though all patients with HIV are likely to benefit from statin therapy, which is sort of a tricky distinction there. All right. Getting into our next M, of mobility. How do we identify patients at highest risk for falls, frailty, and fractures? Know that frailty confers an increased risk of disability, institutionalization, and mortality, with a 2.4 greater risk of death amongst frail adults with HIV. The cost of frailty, falls, and fractures is also astronomical. So cost of hospitalizations for falls far outweighs that for stroke because of the volume of patients that fall in any given year in the United States and the frequent need for rehab afterwards. One really lovely abstract from Corey this year was that amongst persons with HIV over 40, if you could prevent pre-frailty and frailty, you could save 2.9 million life years and $16.2 billion. I don't think we're going to come anywhere close to preventing all pre-frailty and frailty, but what a world that would be. The reason to even propose this sort of hypothetical, what if we could prevent all frailty, is that frailty is modifiable. It is not a state that you are stuck in and need to be stuck in for the rest of your life. We can improve frailty status. One of the reasons this is incredibly important in people with HIV is that people with HIV seem to be at a higher risk of frailty due to quicker losses in muscle mass as they age. So this is now sort of an infamous graph looking at gait speed and grip strength in men living with HIV. The top line in both charts is people without HIV, bottom line is people with HIV. And we see divergence of those curves around age 40 to 50. And by the time people hit their 70s, we are seeing gait speeds in a 70-year-old population, or 70-year-old group of people with HIV in their 70s looking like the gait speeds we would see in people in their 80s. Similarly with grip strength, there's about a 5 to 10-year divergence. This effect is greatest in those with a higher cumulative viral load. So more years off of therapy, we see faster loss of muscle mass. How do we best screen for the patients at highest risk? There's not a lot of data suggesting that any one of these strategies is better than the other, but know that we have a lot of strategies you can use. We are all trying to figure out what is the most efficient way to do in-clinic assessments of someone's overall frailty status. Some of the top contenders are just measuring the gait speed, looking at a timed up and go, so 3 meters, get up from a chair, walk 3 meters, walk back, sit down. How long does that take them? How many times can they stand from a chair in a minute or 30 seconds? Grip strength as a corollary to overall muscle mass, and then using frailty indices. Can we abstract data from the EMR to get a sense of how frail someone may be? To know which is best is going to take a lot of real world utilization of these tools to figure out what's the most acceptable and the fastest, as well as most reliable. Inclusion of functional outcomes is increasingly present in clinical trials, which will help us answer this question. That was one really refreshing thing to see in a lot of the CROI data, is that people are actually concerned about whether or not their interventions make a difference for someone's overall mobility. What do we do when we identify someone who is frail or at risk of frailty? Right now, exercise interventions have our strongest evidence base. I will tell my patients that you're going to hate to hear this, but I got news for you. Exercise is still the #1 thing that your doctor is going to tell you to do. They say, okay, well, where do we even start? Likely, whatever they can do is probably the best answer, similar to answer about PrEP. If you had your pick, resistance exercises and mixed modality exercises that include resistance are probably most likely to help modify frailty. Tai Chi is kind of a standout for fall prevention. Outside the clinic, what can you tell your patients to do? One is to send people to physical and occupational therapy. Decrease grip strength, slow gait speed, any fall. These are all justifiable diagnoses as far as Medicare is concerned for getting someone into physical therapy, so maintain a very low threshold. Also help them identify low-cost exercise programs, especially silver sneakers programs available at most community centers in the US. And don't forget to prescribe an exercise plan. If you tell someone, I am writing you a prescription for XYZ type of exercise, they are more likely to do it. Something magical about that prescription pad actually works. All right, moving on to mentation. One of the big questions is how do we detect and prevent neurocognitive decline in our long-term survivors? Know that HIV increases the risk not just of HIV-associated neurocognitive disorders or HAND, but also age-associated dementias, are more common dementias such as Alzheimer's disease and vascular disease. One great trial presented at CROI indicates that there is a higher risk of all types of dementia, so any age-associated dementia, not just HAND, in people who delayed initiation of ART. So we know that people are higher risk of HAND if they had a lower CD4 nadir or more years without therapy. This seems to also be true for all types of dementia. Hazard ratio about 1.2. Even in our this era of excellent antiretroviral therapies, HAND is still very common. I mean, present in about 30% of our patients. Usually those symptoms are quite mild, so not rising to a level of functional impairment, but more what we would consider mild cognitive impairment. And it can be very, very frustrating for patients. in part because it is a subcortical cognitive impairment. This leads to a lot of difficulty with processing, attention, multitasking, in severe cases, even psychomotor slowing, not necessarily the memory impairment that we classically associate with Alzheimer's disease and other related dementias. So patients can't tell you, yeah, my memory's bad and I can't do anything. Instead, they're bothered by this constant nagging difficulty in completing tasks quickly or completing multiple tasks at once. Right now, the only proven treatment is ART. How do we identify patients experiencing dementia or hand, and how do we differentiate them from one another? Fall back on some of our sort of standard clinical screening tools. The two that I think are most important for HIV clinicians to know are the mini-cog and the MoCA. The mini-cog is a 3-item recall and a clock draw. It's extremely fast, can be very useful in a busy clinic to just reassure yourself or the patient. A normal mini-cog makes it very unlikely the patient has any significant cognitive impairment, but can prompt further testing if they do not perform well. And then the MoCA, amongst our office-based testing, sort of stands out as being more sensitive for hand than our other options because of inclusion of more visual, spatial, and executive function that can pick up on that subcortical deficits. There are increasing interest in biomarkers as a sign of neuronal damage. This is not quite to the clinical stage yet, but no, this was another hot topic amongst researchers at Croy this year. Can we support some of our in-office cognitive-based testing by actually doing blood-based testing of neuronal damage? Can we show that brain injury is happening both in real-world function and in the blood? The mini-cog and the MoCA are great for picking up on the presence of cognitive impairment. They're not great at differentiating hand, these subcortical dementias from a cortical dementia such as Alzheimer's disease. And right now, the gold standard really remains neuropsych testing. This is the best way that you can differentiate the patterns of cognitive impairment that distinguish the two different disease states. It's 3 to 4 hour battery of testing. It can be pretty brutal. It can be hard to access. Most neuropsych practitioners are booking months and months out because they can only see like 2 patients in a day. But when you have those really tricky cases where you're not sure what's going on, this is still the gold standard for figuring out what type of dementia you are looking at so that you can better prognosticate. Also outside the scope of today's talk, I want to highlight advances in neuroimaging and biomarkers. This is a very hot topic in the world of dementia, in part because drug companies are trying to create targeted drugs for Alzheimer's disease pathologies, and you need to know that that pathology is present if you're going to prescribe someone a drug that is meant to intervene. While most of these are not quite ready for full clinical practice, you will start to see more and more people getting amyloid PETs, more and more people getting FDG PETs of the brain, and more serum-based biomarkers of Alzheimer's disease are coming onto the market, though not all are covered by Medicare yet. So keep an eye on this field. This is where you're going to see the most change, I think, in geriatrics over the next 5 years. I don't expect most of the folks working within HIV to become overnight experts in dementia care because it is a complex network of support and diagnoses and expertise that are required to help somebody through this diagnosis and keep them as functional as possible within their home. We need neuroimaging, we need neuropsych testing, you may need a specialist, a lot of therapy support, as well as a lot of community supports. So while I'm not going to get into every little aspect of dementia today, I want you to consider when you go home, do you have an access point for dementia care services? Do you have that trusted clinic, that trusted neurologist, that trusted geriatrician or social worker who can, once you identify dementia in your patients, introduce them to the rest of this world of care? All right, next slide of question. Which therapeutic interventions have shown the greatest level of benefit in improving the trajectory of frailty? All of these featured a quote this year. Got most of the room. All right, that was too easy. I still am glad I put this question up here because know that these other drugs are being studied to help modify frailty trajectories. So there's still a lot of active research in how we can modify frailty and prevent frailty. Also, all of the trials on these drugs include functional outcomes. So even though the letermovir trial was not really looking at frailty trajectories in patients with CMV, by including those functional outcomes, we're able to at least answer the question of what can we do to modify frailty. All right, I will finished with the last M, sort of the most nebulous of our 4 M's, which is what matters most. How do we improve quality of life for people with HIV as they age? This is a very, very broad topic. Major themes that came up in CROI abstracts this year. How do we screen for and improve functional and sensory impairment? How do we improve psychosocial well-being? How do we preserve sexual health and enhance sexual health? How do we prevent, treat, and manage substance use disorders? And then what are some alternative service models we can use to meet patients where they're at? All of these are important for folks' quality of life. And probably a multimodal approach is going to be the most effective if we're trying to improve overall quality of life. Because this is a nebulous one and challenging, people ask, where do I even start? Like, how do I start focusing on what matters most in my own clinical practice? And I'm going to challenge you guys to pick something from this list and roll with it. You're not going to intervene upon someone's loneliness, isolation, depression, or anxiety unless you screen for it. You're not going to intervene on sexual health unless you ask old people about the sex that they're having and they're having it. You need to screen for sensory impairment. You need to screen for functional impairment. All of these are extremely important to the adults that we work with. This is also going to be very different from population to population. Practicing here in Chicago, I can tell you that functional impairment was the #1 concern I dealt with. It was a lot of bad knees, bad hips, difficulty getting around, difficulty getting on the metro or on the bus. In Colorado, it's a lot of isolation. I don't know if it's because there's a lot more rural patients, but a lot of isolation, loneliness, and depression, and they have no worries about their knees. They're hiking mountains. So you're going to have to tailor your interventions to the population that you work with. Make sure that you are ensuring goal concordant care by periodically checking in, especially with your sickest patients, on what they want for themselves. Ensure they have easy access, especially as folks enter and exit nursing care, which is one of the greatest drop-off points that I see in our older adults in staying engaged in HIV care. And if you are more on the research side of things, include patient-reported outcomes in your clinical trials so we can know that what we are doing is actually improving what patients perceive as their health. And then I'll close with sort of I think the most important thing in HIV and aging that comes from a lot of qualitative studies, which is that no matter how your practice is structured, no matter whether you are primarily an internist, an ID doc, what have you, patients trust their HIV care teams and want their HIV care team to be the leaders in their overall care. Even if they have a primary care office elsewhere, even if they're just coming to see you once a year for like their HIV check-in, patients consistently want their HIV team to be taking the lead. And that means we need to be leaders in screening for and addressing geriatric concerns as they get older. All right. With that, I'm under time.
Excellent talk. Thank you, Dr. Walker. And yeah, I encourage everyone to use Slido, the postcards, or just come in person and ask a question in person. So please don't be shy as well. Those are all still options. We got some nice questions that have come through already, so we can sort of maybe get started. A question here, any evidence that simplification to tenofovir sparing regimens in older patients have had any clinical benefit? This individual has a few patients who are well controlled on a 3-drug INSTI regimen who's been asked to switch to a 2-drug INSTI primarily because of fears of overall medication exposure. So a 2-part question, tenofovir sparing versus non, 2 versus 3 drugs, any data to support that, you know, any of these options might be better in older adults?
I'm not aware of any trials. Not aware of any trials looking at 2-drug regimens just in older adults. The older adults were included in most of the 2-drug trials. There is, I can say, no reason to think that they would be less effective other than that our older adults are more likely to have a history of regimen changes due to resistance mutations. So feel free to make the switch. There's no evidence that you are going to be doing any harm, but know that it might be slightly riskier due to treatment experience.
Great. Any evidence that particular ART regimens to avoid or use in patients with hand?
This is a hot topic for which I get into arguments with our neurologists. There is theory that choosing regimens that cross the blood-brain barrier are more likely to both prevent and treat hand. It makes sense. If we can get at the HIV within the CNS, maybe we can somehow reduce the amount of inflammation that's going on, reduce viral replication in the CNS. But to date, there is no strong evidence that that makes a difference. So we do not know for sure that a regimen that crosses the blood-brain barrier is better for hand prevention and treatment. it might be. I think this goes back to the philosophy that the PrEP that the patient takes is the right one. The antiretroviral therapy that works best for the patient and that they can take, especially if they are also dealing with cognitive impairment, is the right one. I would not make a switch just based on a hand.
Great point. What options are optimal for preventing a hepatitis B flare when changing someone from a tenofovir regimen to long-acting cabotegravir potentially, when you're doing that for renal side effects related to tenofovir? So when you're trying to think of a tenofovir sparing regimen, what are strategies in sort of preventing a hep B flare in those cases that you might have come across?
God, I'm the wrong person to ask that question to. That'd be a good question for other panelists.
Yeah, I mean, I think vaccination is really important, obviously, in those who are non-immune, and still recommended if you're withdrawing tenofovir therapy in someone with chronic hepatitis B that's doing optimal or really close monitoring, if that's a shared decision that you come together with. I got a syphilis question here. So how do you, can you comment on when to test for neurosyphilis in patients with cognitive changes or dementia?
You should test. We will continue to be forever frustrated by the syphilis result that we don't know what to do with in our older adults. But it happens, and it happens a lot. I tell all of my trainees that we all roll our eyes when we see someone with encephalopathy in the hospital or delirium, and we say, well, check a TSH and a B12 and an HIV and a syphilis antibody. And everybody kind of rolls their eyes because they're always going to be normal. But there's times that they won't be. Like, you will find the patient who's profoundly hypothyroid and B12 deficient and has neurosyphilis. It is probably safer to err on the side of testing and treating so that you can cross that possibility off the table. If you identify an older adult who has syphilis or has a history of syphilis, that is just one part in better assessing their risk of other STIs, of HIV exposure, et cetera. So it's an important part of the evaluation process.
Excellent. Someone asking, what do you use to screen for sensory impairment in the office? What are some strategies that you use?
I ask, hey, do you have any problems with your hearing? And then you turn to their partner and you ask if they have any problems with their hearing. That's probably the toughest one because we don't have a lot of great office-based hearing assessments. I just ask, and if there's any concern, try to get them into an audiologist. There are cheap options at Walmart and Costco. If vision, you can always do a formal Snellen chart testing, or you can just ask. Usually there's a lot of good reasons you need to send someone to the ophthalmologist anyways, or the optometrist just for updated glasses. The sensation is a little bit trickier. Do ask, check your patient's feet, do a microfilament exam. You'll find that many of our patients, even those without diabetes, have a lot of sensory polyneuropathies as a result of their HIV. That's another thing that very, very prevalent in my Colorado group and was less prevalent here, is a ton of neuropathy. Vision, hearing. I don't really ask about taste.
And then the threat of neuropathy, can you comment on dosing of gabapentin in older patients living with HIV who may be suffering from neuropathy?
Mm-hmm. So gabapentinoids can be effective in some patients for treating sensory polyneuropathies. Because of the risk of sedation and cognitive impairment, will usually try to stick with lower doses. Remember that gabapentinoids are primarily renally cleared, and most of our older adults have decreasing GFR with age. So I will usually not go past about 300 TID of gabapentin or about 50 BID of pregabalin, given the option. I just in practice do not tend to see a lot more therapeutic benefit from higher doses, just higher risks.
Someone mentioning that that they noticed you didn't include food, housing, or financial insecurity in screening for your What Matters Most screening, and noting that in their population, these are really high needs for their patients, and just wondering if that was not borne out of research or data, or why they may have not been included.
I ran out of time and room, but housing, homelessness amongst folks over the age of 65 is rising faster than in other age groups. As people's social supports fall out from under them. So do make sure you are screening for housing stability. Housing instability, food instability, loneliness and isolation also increase the risk for elder abuse, which is wildly underreported in clinical practice. And safety screening, yes. all of these increase the risk for elder abuse and neglect as well, which may impact anywhere from 1 in 5 to 1 in 6 older adults. So if you don't think you've seen any cases of elder abuse, you just haven't asked. Short of asking someone, do you feel unsafe or neglected in your current environment, the only way you're going to get at any of signs of elder abuse or neglect are by inquiring about those other social determinants of health.
Great points. And speaking of sort of housing, what can you comment on sort of nursing homes and SNFs and their ability to care for people living with HIV and older adults living with HIV?
Yeah, so this is a wildly understudied, but the population of folks living with HIV within nursing homes is rising quickly, just with the aging of our patients. It can be a great thing for adherence and engagement in HIV care. You know, have someone in like a supervised environment where someone's overseeing their meds, can get them to their HIV appointments. The biggest kind of hiccup, the biggest problem area is when people are transitioning in and out of institutional care. So in and out of the hospital, one nursing home to another, subacute rehab to long-term care. These are great opportunities for people's meds to just cease and go missing. Nursing homes often aren't sure how to access specialty drugs. They may be reaching out to you wondering where do they get them? How do they pay for them? What do we do? So just be very, very attentive to folks going through those transitions of care. Some really interesting work out of Northeastern looking at Medicare claims data suggests that it may only be like 2/3 of patients with HIV in institutional care actually continue to receive their antiretrovirals. That may be an underestimate based on poor quality data, but still concerning nonetheless. So keep a very close eye on your patients as they enter and exit nursing care.
Great point. Someone asking, other than GLP-1 agonists, are there any other common medications that you feel are being over-prescribed to older adults?
I don't know that I would say that GLP-1s are even necessarily being over-prescribed. I think a lot of folks are a little more afraid to use them in their older adults. The medications that I see being kind of overutilized, overprescribed, a lot of antidepressants that don't necessarily, antidepressants or say antipsychotics for sleep that don't necessarily need to be there anymore. I would say a lot of overuse of same class drugs, especially for pains. A lot of patients end up on multiple opiates or multiple NSAIDs somehow. And then the one that geriatricians will forever rail against is diphenhydramine and over-the-counter meds. So ask about Tylenol PM.
Someone asking, what's your statin of choice? Pitavastatin is not always available for folks. So do you consider Atorva or Suva to be just as good, or you worry about DDIs with certain statins versus others?
I'll admit that often by the time patients get to me, they're already on a statin, and I just say, great, keep it going. I will typically go with pravastatin only because there's a slightly lower reported side effect risk, but if for some reason they can't get that cheap, I am happy with whatever statin does not interact with their current drugs. There's no strong evidence for efficacy for one over the others.
And we're all asking questions to our in-house geriatrician. What is your sleep medication of choice, or how to combat insomnia among older populations living with HIV?
Exercise, set an alarm every day at the same time, CBTI. And then way, way, way down the list, I will tell people like we can trial melatonin, we can trial a low dose of trazodone. If they are depressed.
No alprazolam.
No alprazolam. Essentially try to stay away from benzodiazepines and hypnotics as best you can, due to primarily, while we worry about their impact on folks' memory, the biggest risk is actually falls. So that's the main reason to avoid some of our more sedating meds. Keep in mind that in general, patients don't respond well to sleep meds anyway. Efficacy of people prescribed a first medication for insomnia is like, it's 15-ish% of patients report improvement in their sleep after getting that first drug, whatever it may be. So they don't work that well, which does help drive people towards more effective behavioral interventions. I tell people don't go past 3 milligrams. That's based, it's probably less than that based on how much our body produces, which is like sub quarter milligram. I usually say don't go more than 3 because that's what most of the over-the-counter doses are, is 3.
And wondering if you can talk a little bit more about aging services and how to get a clinic connected to aging services like Silver Sneakers or seniors service centers and whatnot.
Thank you. Great question. We don't all have access to geriatric care, but we do all have access to an area agency on aging. Every single county in the country has an area agency on aging who exist purely to connect older adults to the services available to them. So that is a great place to start. They all go by different names. They might not be called your AAA. But ask around, get a contact there so that you can help connect people to especially housing, insurance, food, and exercise programs are kind of the things that they excel at the most.
Excellent. Going back to sleep, a question about cannabis use and knowing that seniors do contribute to a larger population of cannabis users in the United States. How do you advise the use of cannabis among older patients living with HIV in terms of sleep or pain?
I really just advise extreme caution. There's a lot of great work in this area out of Colorado because of where we are. That all sort of, well, finds two things. One, that our older adults are already using a lot of marijuana products. So ask about it. And finding what we all sort of suspect, which is that the range of side effects that older adults experience when using THC containing products is just very wide. And so you have to be, like, you have to tell people, if you are going to try a THC containing product for the first time, make sure it's for a good reason. Make sure you're starting at a very low dose. Make sure you are going slowly, monitoring for all the things that can cause paranoia, anxiety, GI upset, headaches, etc. There is not great evidence, just because this is often the next follow-up question, not great evidence for its use in dementia-related behaviors, especially because anxiety tends to be one of the most common side effects, and that is often what we're trying to avoid in people with neuropsychiatric symptoms of dementia. But in rare cases, we will still try it, and I give the same advice, just try to go as cautiously as possible.
Excellent. Thank you so much, Dr. Walker, for an enlightening talk. We all appreciate it.